Hello, and welcome to Lupus Treatments, What is a Biologic? I'm Annika Hazlitt, a member of the Board of Directors of Kaleidoscope Fighting Lupus, and your host. In recent years, there have been notable advances in the treatment of lupus and lupus nephritis, and some of the most promising are a class of medications called biologics. What are biologics, and how do they work? Well, to answer these questions and to provide the science behind the medicine, we are fortunate to have Dr. Don Thomas, a clinical rheumatologist and the author of the Lupus Encyclopedia. Before we hear from Dr. Thomas, we'd like to thank our title sponsor, Amgen, for their generous support in making this event possible. We would also like to thank our program sponsor, Pharma, and community sponsors 7 Minute Cinemas, Blue-Eyed Crow Studio, Due North Studios, and Tin Rocket for their support. Now, let's hear from Dr. Thomas.
Thank you, Annika, for that very kind introduction. Did you know that in the past 5 years, and today this is 2023, there have been more FDA-approved indications for the treatment of lupus than we've ever seen throughout the history of modern medicine? And out of all of those, all of them except for one is a biologic. And so today's talk about biologics with lupus is a very important topic. So we'll talk about what biologics are, and very importantly, are they any better than other drugs that we use for lupus, such as methotrexate, azathioprine, and mycophenolate. So let's get started. So first, as far as biologics, it goes by a lot of different names, including biologic drugs, biopharmaceuticals, biotherapeutic medications, and biologics. I like to say biologics just because it's a lot easier and a lot simpler, and that's what I'll use throughout the rest of the talk. Now, you can divide drugs up into two major categories. There is the biologics versus the small molecule drugs. The small molecule drugs are the drugs that you usually think about, such as aspirin and most antibiotics, methotrexate, azathioprine, and mycophenolate. Small molecule drugs go by other names, such as chemical drugs and synthetic drugs, while biological drugs are made by biological processes. Chemical drugs, they're made in the laboratory by combining different things. They have a definite recipe, and you have a definitive or definite outcome from that particular recipe, and anybody can do it. And just an example is just taking baking soda and vinegar at your home. You add vinegar up on top of baking soda, and you get this foamy, very different product than the original products themselves. And more importantly, someone can do this in Canada, and it's going to be the same as someone who does it in Australia. And it's going to be the same product no matter what, which is very different than biologics. And then the chemical drugs or small molecule drugs, they can be given as pill form, capsule form, or injectable, either one. But the biological drugs are very different. Their factories are very different. They're made usually by bacteria, produces the drugs, and inside of the factory you see these huge tanks that are just full of the bacteria making the drug. And I actually visited one of these at one point in the past, and they're quite interesting. When you walk into the factory, the very first room that you come into, you actually take off your clothes and you sterilize yourself, and you wear sterile garb from the top all the way down to your feet. And then you go into a second room and you do an additional form of sterilization as well at that point. And then and only then can you actually enter the actual factory. And the reason for that is if one microbe were to accidentally get into one of those big vats of the bacteria that are producing the medication, the entire thing would be ruined. And this is one reason why biologics are so expensive. Another way to compare small molecule drugs to biologics is to compare them to, let's say that we call a small molecule drug a Lego car. For example, a Lego car is very simple to build, just has a few different pieces that you put together. But then the biologic would be like a spaceship, much more complicated. much more expensive to produce and a lot more complicated on how it works. And because of these things, biologics are incredibly expensive. For example, let's take aspirin. If you take one aspirin, 81 milligrams a day, very common drug that we use in lupus to prevent heart attacks, strokes, and blood clots, it's only about 15 cents per week. But a biologic such as Benlysta, which is one of the FDA-approved drugs for systemic lupus, it costs $1,384 per week. That's 9,000 times the cost of taking aspirin for a week. Now, you might say that's an unfair comparison. Aspirin's been around a long time and is inexpensive. So let's take another drug, methotrexate, commonly used to treat lupus. 7.5 milligrams per week, a very common dose. Methotrexate at that dose is about $6.25. It's still 220 times the cost of taking Benlysta. So it's very expensive compared to other medications. Benlysta, on average, or according to UpToDate.com, is $72,000 per year. And by the way, biologics are being used more and more in the treatment of rheumatic diseases. For example, 1% of the population has rheumatoid arthritis. 70% of them take a biologic. This is one reason why your healthcare costs and your premiums and your copays are going up so much with your insurance plans. A lot of it is being driven by the cost of biologics. So what was the first biologic? It's helpful to look at that first one so you can understand a little bit more about them. It was actually human insulin in 1982. And just to kind of describe how insulin works and how it came about to become a biologic, let's look at what happens with diabetes. So with diabetes, we look at the pancreas. In the healthy person, the pancreas, which is a large organ that sits inside of the abdomen, just behind the small intestines and behind the stomach, it produces a particular product called insulin. And insulin is required in order for glucose to go inside of the cells so that the cells can use glucose, because all of the cells of our body require glucose for energy. But what happens in the person who has diabetes type 1? There's two types of diabetes, type 1 and type 2. Type 1 we oftentimes call insulin requiring diabetes, and also juvenile onset diabetes. Well, it's actually an autoimmune disease itself. Biologics are commonly used for autoimmune disorders. So the immune system of the person with diabetes actually attacks the beta cells of the pancreas. The beta cells are the particular type of cells in the pancreas that produce insulin in the first place. It attacks those beta cells. They are unable to produce insulin at all, and then that glucose cannot go into the cells of our body. So the glucose levels rise inside of the person who has diabetes. Since the cells are unable to use glucose for energy, and there's a large amount of glucose inside of the blood, both of those things combined damage the organs of the body and eventually can cause significant harm and even premature death in people with diabetes unless they use insulin and replace it all the time. So how does insulin work? It's an important component when you're trying to figure out what biologic to use for different drugs. You have to look at what you're going to make and how it works. Well, the cells of the body, they have a receptor on their surfaces called the insulin receptor that can actually bind to insulin. And then you also have glucose channels, which actually allow glucose to go inside of the cells. Now, usually those glucose channels are closed. They're not open. It requires insulin to actually go inside of the insulin receptor like a lock and key. Now, with biologics, the word receptor is a very common term that we use because very commonly something binds to receptors, or even the biologic itself will bind to the receptor. A receptor, just think of it as an attachment for something. The insulin receptor, think of that as the lock, and think of the insulin itself as the key that opens up that lock. When insulin goes inside of the insulin receptor and attaches to it, it opens up that glucose channel. And then, and only then, can glucose go inside of the cell so that the cell can use it for energy and be healthy. So in order to give someone this insulin, you have to think about how is that insulin produced? Well, it's made by the pancreas beta cells, as we talked about. And inside of each beta cell, there's a nucleus that has DNA in it, especially insulin DNA, genes that actually produce the insulin that's required. Well, scientists were ingenious back in the late 70s and early 1980s, and they figured out how to take that DNA that produces insulin, and then they combined it with the DNA of bacteria. The DNA of bacteria is called plasmid. And the name for this, where you take DNA that you want to have, use it to produce something and combine it with plasmid, we call that recombinant DNA technology. And that's an important term because you're going to hear that a lot or read it a lot if you read or see things about biologics. Recombinant DNA, just think of it as recombined DNA, combining one type of DNA like human DNA with the bacterial DNA. And then we trick the bacteria into producing the proteins that DNA wants to produce, and in this case, insulin. So we make these big vats of bacteria producing this insulin, then isolate out the insulin, put it into little vials so that the person can inject themselves with the insulin. So this is a picture of how insulin looks when you look at one molecule of insulin, and look how complicated it is. Each of those little round things that you see is actually an atom. So it's made up of hundreds of different atoms combined together, and it's a very large and fragile molecule. You can't swallow insulin because it would be destroyed by the stomach. It has to be exactly in this shape in order to bind to the receptor and cause it to do what it needs to do. Let's compare this to a small molecule type of medication. For example, azathioprine, also called Imuran, goes by the brand Imuran, which is a common one that we use to treat lupus patients. This is what it looks like. You can easily count the number of atoms that are combined together to make Imuran. It's a very stable molecule. People can actually swallow it and it's not going to be destroyed. And let's compare it to Biologic. In this photograph here, or this slide here, we're showing a picture of a monoclonal antibody Biologic. Now that's a very important term as well. You're going to hear monoclonal antibody quite a bit when you hear about biologics, because most of the biologics that we use to treat autoimmune diseases are monoclonal antibodies, and they're usually in the shape that you see there, kind of a Y shape. It has to look exactly like that and stay like that in order for it to work. But look at all those atoms. There's hundreds of atoms, if not thousands of atoms, in that, much more complicated and much larger than the Imuran molecule. And because of this, Imuran, you can easily swallow it. It's made to be very stable. When the scientists come up with different small molecule drugs, some of them require an acidic environment and can be absorbed in the stomach. Some of them require an alkaline type of environment and are better absorbed in the small intestine. And then the body can change them into however they need to be changed to help the person for whatever indication is needed. But for insulin, it has to be injected. People inject it every day, once or twice or 3 times per day, or even more, or it can be given through IV or infusion form, and all biologics are this way because of this process where they're just too complicated and they would be destroyed if they're swallowed by the person. So let's go through kind of a semi-summary. We have a lot more to talk about with biologics, but let's kind of summarize what we've already talked about. So biologic drugs, they're complex, very large molecules, very sensitive, and would be destroyed if someone swallowed them, so they have to be injected through either the self-injection subcutaneously right under the skin by the person, or through an IV or intravenous form. They have very complicated ways of working, and they're made by living biologic systems, and that's where the word biologic comes from, and bacteria is the most common way that we make back the biologic drugs. So monoclonal antibody biologics is the most common type of biologic that we use for people who have autoimmune diseases. An easy way to think about this is just to call it a biologic antibody. Monoclonal antibody, I think that that's kind of a redundant type of thing. The opposite of a monoclonal antibody would be a polyclonal antibody. The word mono comes from the Greek word for one. Clonal comes from the word clone, meaning a type. And so we want just one type of antibody when we make a particular drug or medication. We don't want to have a whole bunch of different types of antibodies or polyclonal. So monoclonal antibody, biologic, just think of it as a biologic antibody. So how do you formulate a biologic? And this is a good way to kind of think about how autoimmune disease biologics work and how they come about in the first place. So let's think about insulin as a good example. We want to help the disease called diabetes type 1. And then we have to ask what types of problems occur in this disease. Well, with diabetes type 1, the person does not have insulin. We need to replace that insulin. And what natural substance can help? And it is the insulin itself. And then the next question is, what DNA or genes can possibly make this substance? Well, with insulin, it's pretty easy. The genes that are found in the beta cells, so the insulin gene, that's what we want to produce. So we want to take the DNA for insulin genes, insert it and combine it with the bacterial DNA, or what we call recombinant DNA technology, and then we trick that bacteria into making the biologic or the insulin for us so that we can extract it and have the patient use it. So now let's talk about the disease that we're here for in the first place, and that's lupus. What disease needs help? Lupus, of course. And so when we try to think about biologics that can help lupus, we have to ask ourselves, how does the immune system work in the first place? Well, the immune system is there to protect us. And healthy people who do not have an autoimmune disease is there to fight off foreign substances that get into our body or cancer cells. And we'll just use an example of bacteria. In this slide here, you can see bacteria on the top that's kind of in the shape of E. coli, by the way, which is one type of bacteria. And on the bottom, the round ones, they're kind of in the shape of Staphylococcus or Streptococcus bacteria. Now, everything that comes into our body have different types of proteins and carbohydrates and lipids on them that are kind of signatures for those particular things. And look at the bacteria at the top. It has these things called antigens. Antigens, think of them as identification badges. And the antigens that we find in E. coli that you see on the top are very different than the antigens that you see on the Staphylococcus or Streptococcus on the bottom. And those help identify the things that we're trying to fight against in the body. Well, antibodies are the way that we protect ourselves from the antigens of invaders like that. And these are produced by the B, what we call B lymphocytes. But the person who has lupus, it's very different, unfortunately. The immune system, it can't tell the difference between foreign invaders and the own person's own cells. So what does the lupus immune system do? It thinks that that person actually has foreign, like this picture of the pirate that you see. And so the lupus immune system attacks the person's own cells and causes lupus, just like this picture that you see of this young man who has the classic malar rash or butterfly rash of lupus. And by the way, this picture is to remind us that 10% of our patients who have lupus are men. We don't want to forget about the men who have lupus because we usually think about women, because women do constitute 90% of our patients who have lupus. So how does this happen in the person who has lupus? Well, inside of our cells, we have lots of cells. And in each cell, or in the vast majority of our cells, except for red blood cells, each of these cells has a nucleus. And inside of the nucleus, that's a lot of important things are in there, such as the DNA. The DNA actually includes the genes or genetic code that makes us who we are. Well, inside of the person with systemic lupus or lupus, the vast majority of you who are watching this, you were diagnosed because you came up positive for something called anti-nuclear antibody. Just think about that. That's an antibody that actually can attack your own nucleus. And then other people, 70% of lupus patients, they have something called anti-DNA antibody. It can actually recognize, and then it thinks that the person's own DNA is a foreign body, and it attacks it. Now, most of the time, the nucleus and the DNA, they're sheltered from the immune system. They're inside of the cells. But just think about it. Unless you are sitting underneath an LED bulb right now, if you're sitting underneath incandescent or fluorescent light bulbs like I am right now, in fact, these are probably pretty strong. These, even though it's a small amount of ultraviolet light from these light bulbs, it's contacting the skin, and unless the other people in this room are not wearing sunscreen, it's actually damaging the cells underneath the skin, and it's going to cause these healthy people to get wrinkled and also to develop freckles and even skin cancer. And in my family, we get a lot of skin cancer, so I'm actually wearing sunscreen right now, even though I'm inside. But those cells in the lupus patient, they become damaged. They extrude their DNA and nucleus out into the person's body, into the blood and the lymphatic system, and then that anti-nuclear antibody, the anti-DNA, and multiple other antibodies attached to them form what we call immune complexes, float throughout the body, and then land inside of different organs where it can cause inflammation and damage. Even things such as lupus nephritis, which is where there's inflammation of the kidneys. Anti-double-stranded DNA loves to do that. So this is the person who has lupus with that malar rash, and we can ask ourselves, where do antibodies come from in the first place? Well, as I mentioned earlier, they come from B cells or B lymphocytes. B lymphocytes and B cell, it means exactly the same thing. B cell is just a lot easier to say. This is different from T cells, which you'll hear a lot about. T cells are a type of lymphocyte that tell the B cells to become active. So B cells, they don't do anything unless they're actually come into contact with an antigen. On the surface of B cells, there's a lot of receptors, and those receptors, they only attach to one type of antigen. And you know what? Inside of our body, there's actually about 100 billion different B cells. These B cells, they can actually identify about 100 billion different types of antigens. And that's really important because let's look at E. coli, that bacteria I showed you before. It actually doesn't have just one antigen on it. It has a lot of different proteins and carbohydrates and lipids and different combinations. And so it has a lot of different potential antigens. And just think about all the different bacteria and viruses and fungus and different types of cancers that it can invade your body. We need this many B cells in order to identify them and keep us healthy so that antibodies can finally be formed. Now you might ask yourself, how big is 100 billion? Because I like to think about how do we think about these big numbers. It's very difficult to conceptualize. But let's think about seconds, 100 billion seconds. So 1 million seconds, that's equivalent to 11 and a half days. If you had to sit there and count 1001, 1002, 1003, all the way up to 100 or up to 1 million, you'd have to take close to 12 days without any sleep in order to do that. Now, how about 100 billion seconds? That's 3,100 years, or approximately 3,100 years, or 31 centuries. If you were to count 100 billion seconds, you just couldn't do it in multiple lifetimes. In fact, 3,100 years ago was the year 1077 BC. That was before King David and King Solomon of the Bible were even born. That's how long ago it was. So 100 billion is even larger than I can even possibly think about. But it's important for our bodies to make that many different types of antibodies to protect us. So this slide here, you notice that the antibodies are in the shape of a Y, and you'll see that all the time when people show graphics of antibodies. The reason for that is that's actually the shape of antibodies. Remember that earlier slide that I showed you, the monoclonal antibody? As you can see on this picture here, it's in the shape of a Y. The two parts of the Y are the most active areas that can actually attach to receptors or to the antigens that they're trying to identify. So B cell activation, how does it happen? The antigen, it contacts the B cell becomes active, it starts to multiply and replicate, and it starts to make those antibodies that the person needs to protect itself. But a very interesting thing is that when a B cell becomes active, very early on, it retires and it goes through something called apoptosis. Apoptosis is also called programmed cell death for scientists and doctors, but in layman's terms, think of it as the cell dying and that the cell is recycled. It's just like in life. I'm getting older myself. At some point, I'm going to have to retire. The younger doctors are going to have to come along and take our places, and then I'll go back into the ground in my dust form and be recycled some way by the earth. It happens the same way with cells in our body. We want very young, very healthy cells so that we can stay as healthy as we can throughout our life. But if we have an infection or a foreign invader, we don't want those B cells to retire and go through apoptosis, do we? So how do they stay alive? Well, let's say that you get a throat infection. The B cells that see that streptococcal infection, the ones that can identify the strep become active, they start to multiply, they make the antibodies against the strep, but they also call other white blood cells to come to the throat and fight off that foreign invader. Well, the immune system notes that we need to keep those B cells alive, so it makes a type of molecule called a cytokine. Cytokines are simply ways that white blood cells can talk to each other. So when the immune system wants those B cells to stay alive, some white blood cells in the immune system, such as T cells, will make inflammatory cytokines. And one type of the cytokine that it can make is something called BLyS. BLyS stands for B lymphocyte stimulator, and it does exactly as it sounds. It stimulates B cells to stay alive. I think of it as B cell fertilizer. And so the immune system, it makes a whole bunch of this BLyS. The B cells stay alive. They fight against that streptococcus. It causes all those white blood cells cause the pus back in the throat that us doctors can see on physical exam. The tonsils become red and inflamed. It becomes very painful, all the signs of inflammation. But once the bacteria is gone, we want all of those signs of inflammation to go. We don't want to stay miserable like that, to include fevers and things. And so the immune system, we want it to stop and calm down. So the immune system very elegantly stops making that B lymphocyte stimulator or BLyS. The B cells are not stimulated anymore. They've done their job. They can go through retirement and just go ahead and go ahead and die at that point, and retire and be recycled. And then all those signs of inflammation, like the pus and the pain and the swelling and the fever, it can go away so we can feel much healthier and much better. But what happens in lupus? In lupus, it's very different. Most lupus patients who have moderate to severe systemic lupus have too high of levels of BLyS that are constantly high. And this is a bad thing because it's telling those bad B cells that make those antibodies that attack the body, such as anti-double-stranded DNA, to stay alive. In fact, this can be so powerful that these B cells can be immortal. Just think about that. They can live the entire life of the person who has lupus. So this is one target that we can go after to see if we can help people who have lupus. And that's exactly what happened. In the late 1990s, just a few miles from my house, I live in the Maryland area right next to Washington, D.C., a biotech firm called Human Genome Sciences. They discovered this BLyS and how it was usually very high in lupus patients. So they thought to themselves, what if we were to make a monoclonal antibody that can attach to this soluble BLyS and then take it away and see if it would help lupus patients. And so they came up with this monoclonal antibody, and they called it belimumab or Benlysta, which is the trade name. So Benlysta or belimumab, it binds to the bliss floating around in the body. It takes it away. Those cells, those B cells that make that anti-DNA no longer see it, and it says, all right, I can retire. I can go ahead and go through apoptosis and be recycled to make new healthy B cells for the person who has lupus. And when this happens, the person who has lupus, that anti-DNA is not attacking their body anymore. For example, the person who has the malar rash, they can hopefully get the rash better, but it can also help out other organs of the body as well, to include the kidneys. Benlysta is even FDA approved to treat lupus nephritis and get the person with lupus healthy. Hopefully. It doesn't work in everybody, but in those where bliss is a major cause of their disease, it can be very helpful. Because of this, the FDA approved Benlysta in 2011. 2011, the last time a drug was FDA approved to treat lupus was back when Eisenhower was president. Color television sets were just popping up in American homes. I had never seen the FDA approved drug for lupus since the day I was born, until Benlysta came around in 2011. There was much better hope for our lupus patients. So now this doesn't work in everybody, so we need to figure out other medications that can help out lupus patients. So we have to ask ourselves, what other parts of lupus can we help? Well, one of those is a cytokine called interferon type 1. Remember, cytokines are molecules they're ways that white blood cells talk to each other. Some of these cytokines cause increased inflammation. Some of the cytokines can calm down inflammation. But interferon type 1 is an inflammatory cytokine. It increases inflammation, and it's elevated in 75 to 80% of patients who have severe or moderate systemic lupus. Interferon type 1, it's in high levels in our patients, and almost every white blood cell of the body has receptors on its cell surface that can identify interferon. Interferon type 1 binds to that receptor, and then there's a chain reaction within the cell, and then the cell starts to make inflammatory cytokines such as interleukin 2 and tumor necrosis factor alpha that can cause inflammation in the person's body. So if there's some way that we could interfere with this process, it could possibly help that those patients who have high levels of interferon type 1. And so that's exactly what scientists did. They came up with this monoclonal antibody called Safnello or anifrolumab, which is the generic name, that binds to the receptor of interferon type 1. When this happens, when the receptor comes into contact with the interferon cannot bind to the receptor. And because of that, the white blood cell cannot cause those cytokines that cause inflammation. So that leads to less inflammation. But not only that, the levels of interferon decrease in the person who has lupus. And it does help many patients who have lupus, and because of that, became the second biologic approved to treat lupus patients in 2021 when used with other medications that we use to treat lupus. So Benlysta binds to bliss and decreases levels of bliss. Safnello binds to the interferon receptors and helps to decrease interferon type 1 levels. And because of this, one of these drugs may work much better in one person than another. It all depends upon what parts of the immune system are playing a more central role in that person. I have some patients where Benlysta did absolutely nothing, but they're doing amazing on Safnello. I have other patients where Safnello does hardly anything, and Benlysta, though, is doing a great job for those patients. Unfortunately, at this time in medicine, we don't have a way to predict which drug's going to help which person better, and so we do have to do it through kind of a trial and error. But hopefully in the future, I hope that we're able to figure out what medications can help certain patients, so we can have what we call personalized medicine. So where could future biologics help lupus patients because not every patient is going to respond to Benlysta or Safnello because the immune system is incredibly complicated. Well, let's take a look at the immune system. There's many different moving parts. For example, there's complements. You might notice that on many of you, your doctors look at your C3 and your C4 and your CH50 complements, and those can become low in you during active inflammation. In other patients, they can be high. Also, in some patients, they have genetic abnormalities where they have deficiencies in some complements like C4 and C2, and so looking at the complement system is very important in lupus patients as a possible cause or contributor to their lupus. There's another part of the immune system called the innate immune system. Look at all these players on the slide of the innate immune system, and all of these are very important, and many of these are very abnormal in our lupus patients. And then there's the adaptive immune system. This is where the B cells and those T cells are that I was talking about earlier. That also is very abnormal in lupus patients as well. And then look at all of this combined together. The complements, the innate immune system, the adaptive immune system. I show this slide just to impress upon you how complicated the immune system is. And every lupus patient is different. Some patients, one of these or one small part of this immune system problem could be playing a much bigger role in their lupus than another. So we need to have biologics that can possibly help that part of the immune system in those lupus patients. So there's a lot of research going on right now and to try to find other biologics that can help lupus patients. Well, let's simplify the lupus immune system. This image that you see here, this comes from the second edition of my book, the Lupus Encyclopedia, and it makes it a lot simpler. So let's think about how lupus occurs in a patient. First of all, people with lupus are born with the genes that cause it in the first place. We now have identified over 180 genes that are associated with lupus. But in most patients, those genes do not cause lupus to occur unless a trigger turns those genes on. And this is just some examples of some of those triggers, such as ultraviolet light that I was just talking about, or smoking cigarettes, or hormones such as estrogen, one reason why women are much more likely to have lupus than men, and low vitamin D. These are actually areas, by the way, that we can target to help lupus patients, such as giving patients vitamin D, having them use sunscreen to decrease that ultraviolet light from attacking the cells of their body, and definitely not smoking. In the lupus patient, it oftentimes takes damaged cells to trigger the lupus to occur, such as the ultraviolet light contacting the epidermal and the dermal cells. They can extrude their DNA and their nucleus and cause the lupus to become active. And then a part of the immune system called the innate immune system can become active, and it consists of cells like macrophages and dendritic cells that can identify those antigens or the DNA and the nuclear contents of the person. They think that it's foreign invaders. They absorb them into their cells, and then they present those antigens to T cells and tell the T cells to become more active. And by the way, this is one place where Safnello can help. This is one place where Safnello can decrease those interferon levels and stop the dendritic cells from producing interferon and stop that activation of the T cells. But also another part of the abnormal immune system is that the macrophages and dendritic cells can tell the B cells to become more active. The T cells do the same thing, and this is an area where both Safnello and Benlysta can help with decreasing lupus disease activity. Well, if we can decrease any part of the immune system that you can see here with a treatment, we can possibly help lupus patients. And this slide here, everywhere that you see a big red dot, that's an area of the immune system that we can help. And I put the different therapies and drugs there that we use to treat lupus patients. And right now you can pause the video and look at the drugs that you take for your lupus, such as sunscreen and vitamin D and DHEA, methotrexate, mycophenolate, and you can see where your medications help your lupus on this slide. So which is better, taking a biologic or taking a small molecule immunosuppressant drug? This is an important question. Our goal with treating lupus is to get our patients into remission and off of steroids. And so if I have a patient who's on hydroxychloroquine, all lupus patients should be on hydroxychloroquine if they can tolerate it and are not allergic to it or not having side effects to it. So if I have a patient who's on hydroxychloroquine and I have difficulty getting them completely off steroids, in other words, let's say they're on 5 milligrams a day and every time I try to taper it, they flare up. Or let's say that the patient is on hydroxychloroquine and they still have active lupus disease. The next step is to add something to the hydroxychloroquine to get their lupus into remission. And so I talked to the patient about what kind of medications we can add next. And I talked to them about those two broad categories. Should we add a biologic to your hydroxychloroquine? Or should we add a small molecule immunosuppressant such as methotrexate, azathioprine, or mycophenolate? And my drug of choice out of those is mycophenolate, by the way, and I'll show you some reasons why. But not all patients respond to it. Now there's pros and cons to doing both of these. Some patients will end up feeling much more comfortable with a biologic, while others will choose a small molecule immunosuppressant. I have patients in remission on all of these drugs, so none of them are an incorrect answer, but I do think that some are better than others. So we have to ask ourselves the question, which is most effective and which is the safest drugs for our patients? Well, this question was actually asked and I think has a very good answer at our most recent European Union League Against Rheumatism meeting here in 2023. That organization is called EULAR, and it's the equivalent of the American College of Rheumatology, but it's in Europe. Some scientists and doctors who specialize in lupus, they presented this very interesting study, and they asked that very question. Which lupus drugs are most safe and effective for treating lupus patients? But they specifically, in this study, they looked at the efficacy part, or which ones were best for treating lupus, and it's specifically which ones might be disease-modifying agents. Which ones might actually decrease organ damage in the long run? One of the most important questions. So on the left side of the slide, you can see the drugs that we use to treat lupus, and you can find the ones that you're being treated with on that side. On the left side, the top ones are steroids and hydroxychloroquine. Then you see the immunosuppressants, and then at the very bottom are 4 commonly used biologic drugs that we use to treat lupus. So this is in 3 major categories. The first column that you see here, this is for the first year of therapy in lupus patients. The second huge column that you see, this is the years 2 through 5. And then the last column that you see, this looks for the drugs that actually are disease-modifying agents after 5 years of usage. So let's go through each of these columns individually. So in the first 2 major columns, the year 1 and then 2 through 5, we have 3 different columns in each of them. The first column that you see, that looks at studies that look at drugs that decrease inflammation and decrease disease activity in lupus patients. Everywhere that you see a green dot that signifies that medicine for that particular thing that they're looking at shows significant improvements for that particular thing. If you see a yellow dot, that means that there are some studies, but it's not as convincing as the green dot medications. And then the red dots mean that there are actually no studies to show that it helps out with that. The top 2, steroids and hydroxychloroquine, they get a green dot. They do help out right away in that first year with our lupus patients. In fact, steroids are the only drugs that work immediately, and that's why we oftentimes use them to help out patients who are having moderate to severe lupus. Then look at the immunosuppressants. Only 3 of them get a green dot, and that's cyclophosphamide, leflunomide, which is also called Arava, and then mycophenolate, which we also call Myfortic, or Cellcept. Now, methotrexate, it gets a yellow dot. There are some studies that show evidence of it helping, but unfortunately, azathioprine does not have any good studies to really show that it helps out with this. It does actually. I definitely have patients who definitely get benefits within the first year, but as far as research studies, they couldn't prove it. That's the only thing with that. Now, you see one drug on there called misorbine. I'm going to completely skip that. It's just not a good drug. We don't use it in the United States at all. But now look at the very bottom, the biologics. The biologics, every single one of them get a green dot. So all of them have proven that they're beneficial for treating lupus patients. There is abatacept, which is also called Orencia, anifrolumab, which is Safnello, belimumab, which is Benlysta, and then finally rituximab, which is also called Rituxan. And these are 4 commonly used biologics. Now let's look at that second column. The second column is looking at the drugs that decrease severe flares. Decreasing flares is incredibly important in lupus. Every time someone has a severe flare, they have a 2.5 increased risk of having ongoing permanent organ damage for every single flare that they have. Even mild to moderate flares increase permanent organ damage by 50% for every flare. So we want to get rid of those flares. So the scientists ask which drugs significantly decrease severe flares. Well, look at the biologics. Safnello, Benlysta, and Rituxan get a green dot. But look at the immunosuppressants. None of them get a green dot in that particular category. There is some evidence that steroids and hydroxychloroquine decrease flares. They absolutely do. But none of the immunosuppressants showed this. Now, they all do, by the way. I definitely have patients who get benefit with decreased flares, but there's no research studies to prove it. Now, let's look at that third column. The third column is a very important one. We always want to get our patients off of steroids or like prednisone, and I'll show you why in just a little bit. But we want to look at the drugs that are what we call steroid-sparing agents or can decrease steroids in each of these large categories. So in the first year with hydroxychloroquine, steroids, and the immunosuppressants, none of them get a green dot for this particular category. Some of them have some evidence, such as, for example, azathioprine does, methotrexate does, mycophenolate does for this particular steroid-sparing part in the first year. But now let's look at the biologics. Both anifrolumab, which is Safnello, and belimumab, Benlysta, get a green dot for that particular category. In fact, both of them, we can call them steroid-sparing agents. Now let's look at years 2 through 5. Again, look at the ones that get green dots. It's only Benlysta and Safnello. None of the other biologics get a green dot in that particular category. Rituximab gets a couple of yellow dots, but abatacept or Orencia gets red dots in all of those. But even worse, look at the immunosuppressants at the top. The only one that has some evidence for all 3 of those categories is mycophenolate. In fact, look at the mycophenolate row all the way across. It gets more green and yellow dots than all of the other immunosuppressants. You know, before this study came out, myself and other lupus experts, we considered mycophenolate to probably be the best immunosuppressant in our patients, and I usually recommended it as the first drug of choice. And so it was very affirming to me that I saw these results when it came out in this particular study. The one that did worse in the immunosuppressants is azathioprine or Imuran, and so it does end up being my last choice for most of my patients. I usually offer them mycophenolate first, and then methotrexate as a second choice, and then azathioprine as the third choice. But now, which drugs are disease-modifying agents in the long run? Which drugs actually help our patients in the long run to treat our patients who have systemic lupus? And the last row that you see answers that question. Only hydroxychloroquine and Benlysta get a green dot showing that they are truly disease-modifying agents. Now, Safnelo or anifrolumab, it gets a red dot mainly because it has not been out long enough. It has not had any 5-year studies because it hasn't been available for 5 years or longer yet. So we're waiting to see what it does in the long run. And so we can't say it's not a disease modifying agent because there's just not the data there. But all the immunosuppressants get a red dot. There's just not enough evidence, even though they've been available for decades, to show that they actually decrease disease or damage in our lupus patients. And then before I finish with this particular slide, I want you to look at that very top row, prednisone or steroids. Now you'll notice that there's 3 red dots that have an X in them. Red dots with an X means that there's actually studies that show that particular drug does just the opposite. Look at the very last row. It actually causes organ damage instead of decreasing organ damage. It actually causes things such as cataracts, heart attacks, and strokes, permanent damage to the skin, diabetes, all of those horrible things. And so because of these problems with prednisone and glucocorticoids, we have a saying in rheumatology that the P in prednisone stands for poison. I want to emphasize this point because some of you who are watching this video right now have told your rheumatologist that you don't want to take an additional medicine, that you want to stay on prednisone instead because it makes you feel good and it's cheap and and you think that it's safe for you, but it's not safe. You need to work with your rheumatologist to work on using another medication to get you off of the prednisone because it will absolutely cause side effects in the long run, even in low doses. So now the other question with comparing biologics and immunosuppressants is which might be the safest. Now we truly don't know, and that's why I put a question mark on this slide. But I do have a hint in my own mind of what I think may be most safe. And the reason for that is because of my 30 years of experience in using all the immunosuppressants in multiple patients over the decades and how they compare to the biologics. For example, when I follow my patients who take Benlysta and Safnelo, the 2 main potential side effects that I think about are infections and infusion reactions. So when we treat lupus patients, the only drug that does not increase infections is hydroxychloroquine. Every other one does increase the risk of infections. And there's a very important reason for this. Lupus is a disease where the immune system is overactive. So the only way to treat it is to calm it down. So there's this balancing act. We want to calm it down enough to help the lupus, but not so much that it causes infections. And so we want to think about this, and we always tell our patients if you ever get an infection, you want to stop your immunosuppressant, to include Safnelo or Benlysta. Now, when you actually look at the research studies, and you look at with the percentage of patients who get infections on Benlysta and Safnelo versus placebo, there's not much difference, by the way. It's just a small percentage increase in both of them, except for Safnelo and shingles. It's very important to get your shingles shot before you do get Safnelo. That's the most important thing. So now let's look at infusion reactions. So anytime we put an IV into a vein, that's called an infusion, and both Benlysta and Safnelo can be given by infusion like that. Sometimes someone can have a reaction to the infusion, and the symptoms can include things such as hives or rash, shortness of breath, the heart pounding, fatigue, joint achiness, fevers. And then the nurses, when they see that, they'll stop the medicine right away, give some Benadryl, steroids, or Tylenol to help the patient out, and usually that takes care of it. Now let's look at the actual numbers on how often this happens. They did a study looking at Benlysta and asked this very question: how often does it cause serious infusion reactions? So they took 4,000 people and they treated them over a full year. Half of them, or 2,000 of them, got Benlysta plus other lupus drugs. The other 2,000 got placebo, just a fake water or normal saline through the IV, plus other lupus drugs, and saw what they did over a year's time. Well, in the patients who got a fake, just normal saline through the IV or the placebo, there were actually two serious infusion reactions. Just getting an IV can do it. So these patients, I suspect, may have just had a panic attack or anxiety disorder. The heart racing, feeling short of breath, feeling horrible. But the doctor didn't know, is this a panic attack or is this a serious infusion reaction? They had to stop the IV and treat the patient and just assume it was a serious infusion reaction. Now let's look at the Benlysta group. In the Benlysta group, only 8 people, 8 out of 2,000, had a serious infusion reaction. So there's just a 6-person difference between Benlysta and placebo. So fortunately, serious infusion reactions are very uncommon with these drugs. But let's look at the small molecule immunosuppressants. Look at this list of side effects. This is not all of them, by the way, but this is the most important ones. All of them can cause infections. I've seen many infections on these medications over time. We always tell our patients to stop them during infections. Non-melanoma skin cancers, that can potentially be increased with medicines such as methotrexate, mycophenolate, and tacrolimus and cyclosporin, for example. Allergic reactions can happen with any of them, just like with the biologics. And then we have to monitor the blood counts and the chemistry panel for the liver function tests on a regular basis. In fact, we oftentimes do this every 2 to 4 weeks when we start the person on these drugs, because these are real potential side effects. Fortunately, they tend to be mild, and we're able to take care of them in the vast majority of our patients just by simply lowering the dose or stopping the medication. So don't let these scare you because we monitor the drug so closely, but it is a big difference when you compare it to the biologics. We're not going to truly know which is safest and which is most effective unless we truly do what we call a head-to-head study, comparing them just right next to each other. The best study would be to have a large group of patients who are given hydroxychloroquine plus a biologic right when their lupus starts, and then compare it to a group of patients with lupus who get hydroxychloroquine plus a small molecule immunosuppressant. Have the patients and have the doctor blinded as far as which is which, as far as what they're actually getting for treatment, and then follow them over about 7 years or so and see what actually happens. What percentage of patients actually get side effects, and which ones actually get the most help for their lupus over time, and that way we can answer this question. So I'm hoping that someone would do that study, and I think that mycophenolate would probably be the best drug of choice to do it. I have heard when that someone is thinking about doing this particular study, and I hope it comes to fruition. So that way I can truly tell my patients what the best drug is for them to use. So the most commonly used biologics in systemic lupus patients, and we're coming to the end of this talk, are Saphnelo and Benlysta. They're the only two FDA-approved drugs to treat lupus patients. But in some patients, they don't always work. So sometimes we use the medication called rituximab or Rituxan. And also most recently, we've been using a drug called obinutuzumab, also called Gazyva. And by the way, this is a really exciting drug. The studies that have been done so far, just a couple of them, showed that obinutuzumab actually caused a lot of patients to go into remission with their lupus, and there were actually less side effects. We actually saw less serious infections in the patients compared to placebo. Just think about that. Right now they're doing a phase 3 clinical trial, which is a much larger trial. Sometimes those trials will show very different things than what they showed in the smaller trials, but we just can't wait to see what that shows. And right now we are treating lupus patients with this particular drug. But there are other biologics that we use. For example, the TNF inhibitors. These include medicines like Humira, Enbrel, Remicade, Simponi, and Cimzia, and then abatacept, also called Orencia, that I mentioned earlier. Now, all of these drugs, by the way, they're FDA approved to treat rheumatoid arthritis, and that seems to be the best place in lupus patients. They seem to help the inflammatory arthritis in some of our lupus patients, and that's where I primarily use these if other drugs are not working. So next, let's talk about biosimilars. Biosimilars, you can think of them as the generic forms of biological drugs, but there are some important differences. For example, generic drugs or the equivalents of those small molecule immunosuppressants, like I mentioned earlier, there's a definite recipe on how to make them. There's small molecules. One drug company can make it and make it look exactly the same as another drug company. But it's not the same with biosimilars. Biosimilars, they still have to be made by biological bacterial systems, which you can't control completely. They have to be sterile, those factories have to be completely sterile, and so there are some major differences compared to generic drugs. For example, generics can oftentimes be incredibly cheap compared to the brand name medicine, but biosimilars, they continue to be incredibly expensive because they're incredibly expensive to do research for, to figure out how to make them in the first place, because the drug companies who make Benlysta and Safnello, they're not going to share how they make their medication. And then also the factories that produce them, they have to be incredibly sterile, and so all of this is very, very expensive. Another way to think about it is to think about generics as being a sports drink. If you have a sports drink like Gatorade, for example, I'm not recommending people drink Gatorade, I'm just using it as an example, but there's a definite formula on how to make it. You can reproduce it and make it exactly the same, close to 100% as the original makers of the Gatorade, if you know the recipe. Or baking soda and vinegar. Someone in Australia can do it exactly the same as I can, and I can just think of it as being a generic form of the person doing it in Australia, for example. But the biosimilar, think of it as being a comparison to wine. So you can't, the person who makes wine can't control everything. They can control a lot of it, such as which grapes they use, how they ferment the grapes into the wine, but they can't control the weather. You know, if there's a lot of rain when they pick those grapes and they're a lot more plump, the wine is going to be a lot more dilute compared to, you know, the wine that's made during a perfect year where those grapes are perfectly ripe when the grape grower picks them to make the wine. And then they have to be fermented in a large vat, and the winemaker can't 100% control how it's fermented. However, the end product is very similar. You can pour two different Cabernet Sauvignon wines, for example, from different producers, give them to a wine expert. They can swirl it and drink it, and they can tell that it's a Cabernet, for example. But they're going to be very different because they're a biologic product. So in summary, for biologics, the bottom line is that they're made by living biological systems, most commonly from bacteria. They're very expensive to produce. They're made in laboratories or factories that have to be 100% sterile. Even one microbe can damage it. The molecules are very large and complicated. They have to stay exactly like this without any changes in order to bind to those receptors or to bind to those cytokines and help autoimmune diseases such as lupus. And because of that, they cannot be swallowed. They have to be infused by an IV or self-injected by the person themselves. And then unfortunately, they are incredibly expensive. The most commonly used biologics for lupus are Safnello or anifrolumab, Benlysta, which is belimumab, but also we do have other ones, most commonly rituximab and obinutuzumab. Now, which biologics is more effective, or are they more effective than immunosuppressants? We truly don't know. We do need to have that study I told you about earlier. But if you look at that study from the European Union League Against Rheumatism in 2023, here's the chart again. The biologics certainly won big time in this particular study, especially Benlysta showing disease-modifying effectiveness after 5 years. Doesn't mean Safnello doesn't, by the way, because it just hasn't been around long enough. Are biologics safer than immunosuppressants? Again, we truly don't know, but here you can see a list of the most common side effects. I do know when I talk to my colleagues, other lupus experts who use a lot of biologics and know how to compare them, We all think that the biologics probably are safer. We think we see less infections, but we do need to have that head-to-head study that I mentioned earlier of comparing biologics plus hydroxychloroquine versus a small molecule immunosuppressant plus hydroxychloroquine in lupus patients, and hopefully someone will do that study. And by the way, the small molecule immunosuppressants, they work fantastic in a lot of patients. I have had patients over the years, many patients who are in remission on medicines like methotrexate, azathioprine, and mycophenolate with no side effects. When I prescribe these medications, the vast majority never get serious side effects. It's just important that I follow the blood counts, the liver tests, and ask them to stop the medication during any periods of infections. Now, if you're that type of person who would prefer to take a tablet or a pill and not inject yourself, and they're certainly a lot less expensive than the biologics, then an immunosuppressant or small molecule one may be a better choice for you. So, and again, and finally, biologics, you can think of them as being that spaceship. The immunosuppressant, that small molecule, is like that Lego car, much less complicated, much less expensive. Biologics, during the past 5 years, they have become one of the most important types of medicines for treating our lupus patients. They probably are going to be the future, just like they were for rheumatoid arthritis, which has multiple biologic drugs to use in rheumatoid arthritis patients today. And before I close, I just want to make one important comment. If you're taking hydroxychloroquine and you're having any flares at all or active lupus, or if you're on hydroxychloroquine and steroids, even a low dose, and you can't taper it because of flares, you need to talk to your rheumatologist. You need to ask if you should add something on top of it, because your goal is 100% remission from your lupus. And oftentimes we need to try different immunosuppressants or biologics. Ask your rheumatologist what they think about biologics versus small molecule immunosuppressants. Go over the pros and cons, read about them yourselves, educate yourselves about them so you can make an educated decision on your own, get your lupus into remission, and have a much better quality of life. And please consider joining Kaleidoscope Fighting Lupus. They're a wonderful advocacy group to help lupus patients. They show lots of educational programs, just like the one you're watching now, to help educate lupus patients in helping themselves get better. Thank you, and I wish you all the best in life and health.
Thank you, Dr. Thomas, for that wealth of information and for sharing your expertise. This brings us to the end of today's presentation. We hope you found Lupus Treatments, What is a Biologic, informative, and that you share this resource with others in the lupus community. Once again, special thanks to our title sponsor, Amgen, for their generous support in making this event possible. And thanks to our community sponsors, 7 Minute Cinemas, Blue Eyed Crow Studio, Due North Studios, and Tin Rocket for their support. Also, thanks to our program sponsor, Pharma. And we want to thank you for watching. We encourage you to visit our website, kaleidoscopefightinglupus.org, and follow our social media platforms for the latest lupus news, program information, award-winning blog articles, and so much more. Thanks for spending time with us. And remember, you are not alone. I'm Annika Hazlitt for Kaleidoscope Fighting Lupus. Please take care.